question, I would like to call upon the chairpersons, Dr. Atul Mathur, sir. Dr. Atul Mathur is a senior physician, renowned physician practicing in Prayagraj. Dr. S.T. Pandey, sir, he is Professor Neurosurgery, MLN Medical College, Prayagraj. And Dr. M.K. Madnani, sir, he is a renowned senior physician and past president of AMA. I welcome you, sir. I now request the chairpersons to kindly introduce the speaker. Thank you.
Exhaustive session on migraine. Now we have got another interesting topic, diplopia, which would be dealt with by Dr. Arun Kaul. He's got a very academic record. He is a professor of neurology in Jipmer, Delhi, and has got National Faculty Ionacon, Nephrology and Ophthalmology subsection. He has been a principal investigator at Jipmer, Indian Multiple Sclerosis Registry Network, and he has 32 publications to his credit. So he would be speaking on a very relevant topic, diplopia. Dr. Arun Kaul.
My special thanks to the Medical Association Allahabad for this opportunity, and especially Dr. Gulab. So I'll be speaking about how do we approach diplopia. Before we start, can we have a show of hands, residents? Are there any residents? Or MD graduates? Or MBBS students, any? Or none? Okay. So this is a very famous quote by David Kogan that eyes are the windows to the nervous system, because if you carefully notice the eyes, you can know a lot about what happens in the nervous system. So besides being an inspiration for Bollywood, it is tells a lot about the nervous system of a person. So let's begin with the case. This is a hypothetical case, a 33-year-old male with a history of diplopia of 1 day. So after a thorough history and ophthalmological examination, what are the chances that we identify the etiology? And what is the likely chance that this is a life-threatening situation? So I thought that there will be residents, but anyhow. So this comes from the study that up to 80% of the cases of diplopia, acute onset, if you take a very proper history and do a physical examination, a bedside neurological examination, a detailed examination, you will be able to point out to a diagnosis without any need for imaging, and it will be very rare, less than 3% cases where you need to have the condition may be a life-threatening condition. So what are the symptoms of diplopia? Many times the patients will not tell you that he is seeing double, ki do dikh rahe hain. Sometimes the separation between the images is so less that they confuse it with visual blurring. And sometimes they'll tell you that mujhe chakkar aa raha hai, dizziness, imbalance. So you have to dig deep that what he exactly means by when he says ki mujhe chakkar aa raha hai. Defective hand-eye coordination, as Dr. Ashish had already also shown that even in neuropathic cases, similarly if the patient has diplopia, he'll have difficulty doing fine work. And then the difficulty negotiating stairs, this is very relevant whenever any of the obliques are involved. Superior oblique muscle, they usually have a difficulty negotiating stairs, and they especially fear going down the stairs. So the first important question you ask a person when he complains of a double vision is whether it is a uniocular diplopia or a binocular diplopia. So why is this important? The commonest cause of monocular diplopia, and the easiest way to test that, the commonest cause of a monocular diplopia is a refractory error. So we see that patients may be a myopic, hypermetropic, uncorrected refractory error, and at the bedside, just take a cardboard, make 2 or 3 holes into it, and with a pinhole you can correct for myopia and the diplopia will disappear. The monocular diplopia can be bilateral. What do I mean by this? Suppose the diplopia is coming from the right eye. So if I close the right eye, even if it is a monocular diplopia, it will go off. So when we say that the diplopia is binocular, we close the eye, the diplopia disappears. And before we say that it is a monocular diplopia, you cover first one eye. If it disappears, okay. The other eye, if it's again still present, then it is a monocular. So you cover both the eyes alternatively to be sure that it's a monocular diplopia. The other common causes of a monocular diplopia are dry eye, And neurologically important is the cerebral polyopia. We'll come to that. Binocular diplopia, why actually diplopia occurs? We know that the images form on the retina at the fovea, which is where the visual acuity is the maximum, and whenever it falls on any other place in the retina, the resolution of the image is less. So what happens that the patient sees that image as blurred, and it is because of this that the patient has a diplopia. So why would diplopia occur? If the image is not falling on the corresponding parts of the retina, why would that happen? If one of the muscles is weak, one of the muscles is overacting. Suppose we are seeing to the right. When we see to the right, the lateral rectus is acting on the right side and the medial rectus on the left side, and correspondingly the medial rectus of the right, it relaxes. So if the medial rectus also acts and it's not fully relaxing, the patients may have a diplopia. And sometimes, especially in thyroid eye disease, we may have a restrictive ophthalmopathy. We'll come to that, where the muscle is not per se weak, but it is taut and it causes the restriction of the eye movement. So what are the key concepts to remember in case of diplopia? One, I told you that it is maybe a monocular or binocular. And then you see whenever the patient comes with diplopia, you ask him whether the images are tilted or not. So that will give a fair bit of idea that what muscle is involved. One is the direction of the diplopia and whether there is any obliquity of the images, and whether the patient has to turn or tilt his head to make the images, the separation becomes less. So the rule is that the diplopia is always maximum in the direction of the weak muscle. Suppose a right lateral rectus is weak, so when the patient stares to the right, he'll have diplopia, and as far as to the right, the images will separate. And when he sees to the left, the diplopia will decrease, and if it's extreme left, it will go up. But all these rules, they apply in acute onset diplopia, and when a single extraocular muscle is involved, they will not work. When multiple oculomotor nerves are involved, that time we have to look for other signs. So this was primarily for the residents. What is the action of the extraocular muscle? Because it is, if you know the action of the extraocular muscle, you can reduce the diplopia, how it happens. This is a bit important, that whenever a patient comes to you with diplopia or even other complaint which is related to the visual system, you'll first look for the alignment. It is very easy to look for the alignment. I'll come to that. Fixation, you just ask the patient to fixate at a near point, say 30 centimeters, and see if there are any eye movements. Ductions are the uniocular eye movements. You just see for the abduction, the adduction, the elevation, and the depression. Vergence is the disconjugate eye movements. This eye moves to this direction and this eye moves to this direction. That is convergence, and then accordingly divergence. Saccades are important. We'll come to that. Pursuit. Vestibulocular reflex is important in cases where we think that the diplopia is not per se because of the weakness of the muscle, but there is some supranuclear component. And of course, optokinetic nystagmus. This is the corneal light reflex test. When the patient sees into the torchlight, you just have to see whether the image, the reflex of the light is occurring at the corresponding parts of both the pupils. So if they are same, then the patient is said to be orthophoric, that is, there is no deviation. So now you look at the right side of your screen. So in the first image, what has happened, the eye has moved inwards and consequently the light reflex is deviated outwards. Similarly, in exotropia, the eye has moved outwards and the light reflex has moved inwards. Similarly, in hypertropia and hypotropia, just by a light reflection, and you ask the patient to fixate on the light, you will be able to tell which muscle is weak. Along with this, sometimes people with diplopia, they also have ptosis. So this is what we call as the margin to reflex distance. This is very easy to measure. Just see the light reflex and see where the limbus is, where the upper lid margin is, and we can see the lower lid margins also, and this will help you. The distance to the upper lid tells you whether the patient is ptotic or not, and if we look at the lower lid, whether the patient has a retraction of the eyelid, as sometimes, or the inverse ptosis as happens in the Horner syndrome. Most important thing to know, because there are some causes which are treatable. So you have to see whether the patient has the diplopia, whether it is constant throughout the day and night, or it is intermittent. So these are I have highlighted the important causes of transient diplopia. So myasthenia gravis we should never miss. Along with this, thyroid ophthalmopathy and raised intracranial pressure, idiopathic intracranial hypertension. It can also cause transient and intermittent diplopia. This I came across. This was a lady who had a recent onset of this, the deviation of the eye, and consequently diplopia. But as you can see in the right eye, she has developed a cataract. So these patients have a compensated squint which occurs for a long period of time, and then suppose she develops a cataract and the visual fixation from this eye, she is not able to see properly, and it is because of this she has to use the other eye for fixation, and this causes the apparent squint. This is a video. I hope there is no sound. Anyways, I'm asking him to look up and then to the right, to the left. He had diplopia. So you can clearly see that he has ptosis, which is a bit fluctuating. And when you elevate the lid on the right, the left lid goes down. Again, on the left you elevate, and the right. And now here I am asking him to close the eyes tightly, but he is not able to do that. So if a patient has difficulty in opening the eyes, that is the patient has ptosis and difficulty in closing the eyes, that is the weakness of the orbicularis oculi, that the facial. अगर आँख खोलने में भी दिक्कत है, आँख बंद करने में भी दिक्कत है, तो it is, and along with that he has intermittent diplopia, so it is most of the times it will be myasthenia gravis. Another patient, again you will not be able to hear the voice. Anyways, if you just focus on the static image, on the right side you see the eyeball is covered, there is ptosis on the right, and in the left if you clearly see that the limbus is visible, that there is some lid retraction. So a ptosis on one side and a lid retraction on the other side. So this is basically this is seen in a brainstem stroke where we call it as a plus minus syndrome. The plus is for the ptosis on the, like we have on the right, and for the lid retraction on the left. But if it is variable, again sometimes it occurs, sometimes it doesn't occur. Along with this, the patient has diplopia, again facial weakness. So this is called a pseudo plus minus lid syndrome, and this is invariably seen in myasthenia. Myasthenia is very important because you should not miss this. Initially present with the diplopia, and sometimes the delay in the diagnosis is many years. This is another sign which is very specific for myasthenia. You just, I'm asking the patient to look down. You ask the patient to look down for about 45 seconds to 1 minute, and then suddenly ask her to look up. So here she is looking down. I'll just forward it. Just focus on the lids. When we ask her to, here, could you see? Just see again. Patient is looking down for some time, usually 1 minute. Here, when the patient looks up, there is a twitch in the lid. So this is called the Kogan's lid twitch sign, and it has close to 99% specificity for myasthenia. So sometimes we do the SHR antibody that is negative. We look for there is no apparent restriction of the eye movements. But if you do this or the other signs in combination, you'll arrive at a diagnosis, as we saw in the very first slide, that 80% cases you will be able to localize the diplopia just by a history, thorough history, and a physical examination. This thyroid ophthalmopathy is very common cause of diplopia. It's not as florid as I have seen. I have taken a typical case. What I want to impress upon is that it is a case of restrictive orbitopathy. So what does restrictive orbitopathy mean? I'll explain. See the image on the right. Here you see the image marked 1. This is the inferior rectus muscle. See the muscle bulk, how it is hypertrophy. The other is the medial rectus, lateral rectus, and the superior rectus. So what happens in thyroid ophthalmopathy, it is the inferior rectus muscle that is most commonly involved. And here if the inferior rectus is involved, it causes a restrictive orbitopathy. So when you ask the patient to look up, he'll not be able to look up. So otherwise, if there's an inferior rectus weakness, patient will have a difficulty in looking down. But here, if the inferior rectus is involved, the eye will not go up. So that is restrictive orbitopathy. And it's a classic teaching in the residents that in the thyroid eye disease, it is only the muscles that are involved and tendons are spared, as against orbital pseudotumor or a non-specific orbital inflammation, where the muscles as well as the tendons are involved. But now the literature says that the tendons can also be involved in thyroid ophthalmopathy. Coming to the pattern of muscle involvement, this is a mnemonic to remember that the inferior rectus is the most commonly involved muscle, then followed by the medial rectus, then the levators and the obliques. So as I told you, the inferior rectus is most commonly involved. Patient is not able to look up. So sometimes it's called a double elevator palsy. That is, the patient is not able to look up bilaterally. So this again important, the lateral rectus is very rarely involved. So if a lateral rectus is involved, what will happen in restrictive orbitopathy? The patient will not be able to adduct. So if you are suspecting a thyroid ophthalmopathy and patient has an exotropia, so always think of myasthenia. Sometimes both of them can coexist, sometimes they can mimic each other. And the thyroid eye disease and myasthenia, these are intermittent and treatable, so they should never be missed in a patient who comes with diplopia. So after intermittent diplopia, we come to constant diplopia. The most common cause is the involvement of third nerve. So again a video. Just look at the limbus, at the conjunctival vessels. I'm asking him to look down. Yes, here. Just look again, because the localization will depend on the movement. Just see. I'm asking him to look up and now down, here down. I don't know whether you are able to appreciate or not, but there is an intorsion of the eyeball which tells you that the fourth nerve is intact, because in normal conditions, the isolated action of the fourth nerve we cannot tell whether it is acting or not. It's like, say in a relationship, one partner is very dominant, like the third nerve. So it tells you, the third nerve tells ki is taraf dekho, so eye has to look this way. Upar dekho, niche dekho, is taraf. So fourth nerve doesn't almost independently exist. But when the third nerve is paralyzed, then the fourth nerve says ki okay, ab main batata hu ki main kaise kaam karta hu. And this is where the intorsion comes in. So if the intorsion is preserved, that is a pure third nerve. So the localization in case of a third nerve palsy, pupil involvement, you should always rule for especially if the patient has a headache, so always look for the posterior communicating artery aneurysm. So this is a very painstaking study done over a period of 40 years, where 1400 patients were evaluated, just the third nerve palsy, and they found that the trauma and tumor were very common. What is important to know is that we know that in diabetes, because it is an ischemic third nerve palsy, the pupil is usually spared. It can be involved, but it is not to the tune like we have fully dilated and not reacting in the case of third nerve palsy because of an aneurysm. And only 2% of aneurysm spare pupil. So always in a case of third nerve palsy presenting with pupillary dilatation, complete ophthalmoplegia, rule out a PCOM aneurysm. So the dictum is that unless proven otherwise, acute third nerve palsy with the pupillary dilatation is caused by a posterior communicating artery aneurysm. Fourth nerve, again the video is not, it will not be possible without history. This guy had an acute onset difficulty in going downstairs. So, but without voice, there is no fun. Anyways, this is a very easy test. If you do, the patient tells you that there is a tilting of the images, you just ask him what he saw first thing in the morning, say a tube light or a fan, and then just ask him to draw. So if he draws this, like on the right side, the two images, the one is blurred and one is clear, and they are meeting towards the right, so it is going to be right fourth nerve palsy, but provided it's a single nerve palsy, the fourth nerve palsy on. And if the patient views like this, the second image, the arrow is marked to the left, it is going to be a left fourth nerve palsy. So it's very easy to determine just at bedside. Otherwise, it is very, very difficult in case of an isolated fourth nerve to tell which nerve is involved and which is not. So this was again the same person, the James R. Keane, who collected all the cases of fourth nerve palsy over a 23-year period. And then he saw that the inflammation and brain tumors after head trauma were very common. But this is a more recent study, 2019, it was published, and it suggested that the most of the times it is congenital, and when they have a stressor, suppose a fever, a mild trauma, then it becomes manifest. Apart from this, like in third nerve, diabetes or hypertension, that is the ischemic fourth nerve palsy is very common. This is a very interesting thing which happens with the fourth nerve whenever the patient has a vertical diplopia. So this is a Maddox rod in front, but it can be done without a Maddox rod as well. You just have to take object to see when the patient has diplopia. So once the patient is upright, you ask him to measure the diplopia, just like she is showing with the thumb and the index finger, that this is a separation between the two images. And when the patient lies down, if it is case of fourth nerve, there is going to be no change because the muscle is weak. But if it is because of a supranuclear thing, like we say कि जैसे sometimes patient बताते हैं कि ऊपर का कुछ चक्कर है. So here the ऊपर का चक्कर means कि it is above the brainstem. So that is the skew deviation. कोई भी the vertical displacement which occurs above the nucleus of the fourth nerve, it's called skew. And in that, the distance between the two images, it will decrease by more than 50% from upright to supine position. So it is an easy bedside test to know whether the patient has the vertical displacement is because of the involvement of the fourth nerve or it is a skew deviation. So this is about the skew. The sixth nerve, this was again history. So this lady, she had this diplopia. Along with that, she has headache, she has pulsatile tinnitus, and she has the headache worsens in the morning. So that was, in case of sixth nerve, you should always rule out raised ICP, that is the idiopathic intracranial hypertension. So this is the definition for that, we don't require that. These are the studies done at various points in time regarding the causes of the etiologies of the sixth nerve palsy. So it can again, in surgical series, the trauma is the most common cause, sometimes neoplasm, and nowadays it is again ischemic, that is diabetes, hypertension, and of course the important cause we should never miss is the raised ICP. So again, it was after the involvement of the single nerves which cause diplopia, we come to the multiple nerve involvement. So here there is hardly any movement of the eye, of the left eye, and he has ptosis as well. So this is a very common presentation you must have seen in medicine also. We see a lot of patients who come with this, the third, fourth, sixth nerve palsy. And depending on the history and the physical examination, the R localization of third, fourth and sixth along with a slight decreased sensation of V1 and V2 distribution is involvement of the cavernous sinus, and most commonly it is the Tolosa-Hunt syndrome. But what is important to know in Tolosa-Hunt, you see the pain and paresis resolved when it treated adequately with corticosteroids. But this is a before we rule out Tolosa-Hunt, as we discussed in low back pain also, that tuberculosis is endemic in this country. So we should rule out any infection. Most of the times lumbar puncture is to be done, and MRI brain with contrast is to be done, along with other causes to rule out in a case of this. Once we have ruled out all causes, especially in a case of if the patient is a diabetic, because if we give steroids, patient may improve, but then the underlying infection may flare up and we may be in a soup. So always rule out an infection because the definition also says that we have ruled out all other causes. But it is a very common cause. You must have seen this Tolosa-Hunt syndrome. When we don't find any cause, and sometimes they have to be given a long course of steroids, and sometimes they recur also, and you have to give immunomodulator treatment also for steroid sparing. This was again history. Here the patient has bilateral complete ophthalmoplegia. So here I am trying to see the vestibulo-ocular reflex. I am asking him to look in the front as I move the head to see whether the eyes move or not. So this is indeed involvement of bilateral third, fourth and sixth. And he had difficulty in the eye closure also. So as Dr. Ashish told us about Miller-Fisher syndrome, so this was a case of anti-GQN antibody. He had complete ophthalmoplegia and ataxia and areflexia. Initially, he did not have areflexia when he came to us. He came to us on third or fourth day. Now he has almost completely recovered. So it will depend, the management will obviously depend on the etiology. So if it, so acute bilateral ophthalmoplegia, most of the cases are because of the GBS, but again, GBS, Miller-Fisher is again a diagnosis of exclusion. We do the CSF, rule out other causes, do the MRI brain with contrast, with thin cuts to the cavernous sinus, and if everything is normal, in the meantime we send for autoantibodies if they are positive, and then we treat accordingly. This is a young male with diplopia, asking him to look towards the right. If you can appreciate, there's a nystagmus in the right eye, abducting eye, and there's a impairment of the adduction on the left. And when we ask him to look to the left, the right eye is not adducting fully, and there is a nystagmus in the left eye on the abduction. So this is a bilateral internuclear ophthalmoplegia. Usually they don't have diplopia, but they can have if there is a vertical displacement, or sometimes they have an oscillopsia, which may confused with diplopia. So young male coming with diplopia, on examination you see bilateral INO, so it is 90%, 95% of the cases it is going to be multiple sclerosis. So you cannot miss this in a young male. So this was the MRI. Of course he fitted into the criteria of multiple sclerosis. So this is internal nuclear ophthalmoplegia. Apart from MS, the stroke is a very common cause. So we look for this, the elderly male who came with, look at the, he has a ptosis on the right, and here I am asking him to look towards the left. See, left, there is no movement on the left, and when he looks towards the right, there is no movement on the left, but in the right, there is an abducting eye showing nystagmus. So only this part of the movement is preserved. That is just one half of this, one half movement is preserved and 1.5 movement is paralyzed. So this is 1.5 syndrome. It is again, the localization is same, and in elderly, in young it is multiple sclerosis, and in the elderly it is stroke. So 1.5 syndrome. Another young female with this we see commonly, 24-year-old male, 1 year history of headache, migrainous phenotype as Dr. Rupi told us, the classical phenotype headache, but this time she also had a diplopia. So the headache had increased about 1 week prior to the diplopia onset. So what would be the diagnosis if we rule out all other causes? Young female, headache, and now having extraocular muscle paralysis. So this is now named as recurrent painful ophthalmoplegic neuropathy, where the patient has a unilateral headache and ipsilateral paresis of 1, 2, or 3 oculomotor nerves. So oculomotor nerves are 3, 4, and 6. So any weakness along with headache, and we have to rule out any other cause of headache. So we initially it was called for some time ophthalmoplegic migraine also, but there are still strong proponents of this diagnosis that, and this was in Green Journal, a big review, that indeed some migraine is, the ophthalmoplegia is migrainous. I think Dr. Lal from PGI has published a study of a large number of patients where he has documented this, the transient ophthalmoplegia in a case of migraine patients, and when they were followed up, mostly they recover. And if you do the MRI, usually there is enhancement of the nerve involved. This was an interesting case, but here we don't have the history. So she was having triplopia. She was seeing 3 images, and along with that she has this abnormal movements on the left also. So, and if you look carefully, both the eyes are converged. She is, see, as if there is a lateral rectus weakness. The eyes, both of the eyes are converged, as if she is having a convergence spasm, and continuous movement of the left arm. So triplopia is so rare that it is almost always non-organic, and this movement, the convergence, it is usually seen in young females, sometimes anxious females, where mostly association with convergent disorders, and it responds very well to psychotherapy, cognitive behavioral therapy. Here also the problem with this girl was that she had a YouTube channel, but she did not have any adequate subscribers. So that led to this. She was with us for about a month. Initially, we thought this is epilepsy, and then this. So, but as I talked earlier, that the monocular diplopia can sometimes come from a stroke or a demyelinating event in the parieto-occipital junction, where the patient can have multiple images, but here all the images are clear. So, as we saw in binocular diplopia, one image is usually blurred and one is clear, but here it can be multiple, it can be hundreds of images, and sometimes it's called as the entopomopia, that is the insect eye. So, it is a known phenomena. I have seen only 2 cases. But it is a documented entity, that is the cerebral polyopia. Again, it was a history. So here, as you see, the patient, once she looks towards one side, there is a, just see what happens to the eyelid. The eyelid, it narrows down. And as she looks down, there is the co-contraction, that is the both of the muscles, the medial and the lateral rectus, they contract. So this is a Duane retraction syndrome. This is not very uncommon. So if we know the constellation of symptoms, we can get initially we have to get the MRI done to see the secondary causes. But if we know the diagnosis, we'll not over-investigate the patient. Usually they respond very well. This is again a patient who came with severe pain initially, and then she had this eruption. As Dr. Gulab had said, that sometimes the low back patients, they come with only pain, and when you see that there's a zoster eruption. So he had a zoster eruption, and then there was the involvement of the third nerve on the right. So the importance of this is that whenever herpes zoster involves the nasal tip, it's called Hutchison's sign, and it is a predictor of increased involvement of the first division of the trigeminal nerve, and it can cause sometimes blindness also by the involvement of the cornea, and sometimes it can progress to the involvement of the cavernous sinus as well. So if you find such a case, initially you start with the antiviral treatment without waiting for the complications to occur. This is again history. If you see here the 6th nerve is involved, I will forward it. Just look at the tongue, there is the deviation of the tongue also. So if there is an involvement of the 6th nerve, one is always look for the fundus and look for the other nerve involvement also, because it is highly localizing. If there is involvement of the 12th plus the 6th, so the anatomical localization is always the clivus, the base of the skull, the clivus. So this is called the Gottfredsen syndrome, the 6th involvement of the 6th and the 12th. So this is the approach to diplopia, monocular, binocular, then intermittent or constant. If it is constant, whether it is restrictive or it is paretic, and the types, the supranuclear and the intranuclear. So if you wish to see your money double, there are, I think, better ways. So thank you. That's about it. Thank you.
Hello. Thank you, Dr. Arun Kaul, for enhancing our knowledge. And I think the learned audience would have gained more insight regarding diplopia. They may or may not be managing diplopia, but yes, they must have enlightened their knowledge. Thank you. Now the floor is open for any question and answers. Dr. Karthik wants to ask something.
Yeah. It has been reported in few of the cases of the migraine, people present the problem in the eye, or last after 2-3 years we find that we have missed somewhere something. We treated as a general migraine because no reason, nothing. But I have encountered 2 patients, they lost vision. So have you seen this, like this picture?
So whenever we come across a headache, the first question is to ask is whether it's a primary headache or a secondary headache. And in cases of secondary headache, there can be involvement of the vision loss, but per se, as a complication of migraine, we can have a status migrainosus, we can have an infarct, and sometimes if the infarct is in the parieto-occipital region, that can cause a vision impairment, but per se, migraine causing vision loss, I am not aware of that. There is a retinal entity, the retinal migraine, but it is very, very rare. Retinal migraine can cause a...
It's what I have seen 2 cases. They have gone to the All India Institute, RP Institute Center as well. There was no lesion in the MRI everywhere. They had diplopia, we could not explain. After that, I lost the patient, but reported that with the ophthalmologist that they have lost the vision.
Diplopia
It's only
is
finger counting or something like that. That's why it's not like I have noticed in the last 40 years. That's what I'm telling.
Diplopia is known.
Your experience.
Diplopia is known, so diplopia is known, and vision loss as a part of retinal migraine. Apart from that, yes.
That will be apparent during the examination. If patient has any involvement of optic nerve, naturally he may lose the vision. But if ophthalmologically we have seen that the patient has no ophthalmic lesion, and even then it is a loss of vision, it is because of the cortical blindness. You have to see. There are so many things we don't know, even today.
Well, thank you, audience, and thank Dr. Arun Kaul for delivering such a elaborate lecture on diplopia. Quite an interesting symptom and needs to be evaluated very thoroughly. Thank you.
Thank you, sir, for a very lucid presentation. I now request Dr. Ashok Mishra, sir, President AMA, Dr. Ashutosh Gupta, sir, Secretary AMA, Dr. Anubha Srivastav, ma'am, Scientific Secretary AMA, Dr. Gulab Soni, sir, Organizing Secretary of this conference. I request you all to kindly proceed on the stage and honor the speakers and the speaker and the chairpersons. Thank you.